I'm Dr. Meera Mohan from the University of Arkansas for Medical Sciences in Little Rock, Arkansas. Today, we'll be discussing our work, clinical implication of loss of bone marrow minimal residual disease negativity in patients with multiple myeloma. So this was presented at the recent American Society of Clinical Oncology meeting in 2020. Minimal residual disease, or MRD, refers to the small amount of cancer cells that remain in our body after treatment. MRD is a robust predictor of clinical outcome in newly diagnosed multiple myeloma patients. Increasingly, MRD negativity is considered an optimal clinical trial endpoint. We know from various clinical trials that a lot of our patients achieve this milestone of MRD negativity. But little is known about the natural history of evolution of MRD status in patients who attain this deep response. It seems clinically relevant in the current era where a more dynamic, risk-adapted treatment strategies are being explored. Our aim is to follow patients who attained MRD negativity to study the evolution pattern of MRD and its clinical implications. In our study, we included 606 patients with newly diagnosed multiple myeloma. Patients on our study were treated on an intensive treatment regimen incorporating multi-agent chemotherapy and novel agents, followed by a high-dose chemotherapy autologous stem cell transplantation. All patients also received maintenance chemotherapy for a fixed duration of time with novel agents. Patients included in the study had achieved a sustained VGPR or better response in their myeloma, along with bone marrow MRD negativity on 2 occasions, at least 3 months apart. All patients in our study had a comprehensive response assessment by 2 ways. They had PET CT and MRI negativity, along with bone marrow MRD assessment. So the patients were followed by serial labs, bone marrow assessment, and novel imaging techniques till clinical relapse. In our study, loss of MRD negativity or MRD conversion is defined as detectable minimal residual disease by way of a positive flow cytometry assay. MRD assessment in our study was done by 8-color flow cytometry, what we call a next generation flow or a Euroflow assay. It could detect 1 tumor cell in 100,000 cells. The results of a study shows that the median age of this cohort was 57.8, with 63% of patients being male. Most of the patients in our study had low-risk multiple myeloma by way of UAMS GEP70 risk score. At a median follow-up of 10 years, 60% of our patients continued to maintain sustained MRD negativity, while 40% of the patients experienced an MRD conversion from negativity to positivity. Median time to MRD conversion was 6.3 years from diagnosis. Interestingly, the risk of clinical relapse was elevated in patients who had MRD conversion compared to patients who had sustained MRD negativity. The risk was elevated by 3.5 times, and this predicted clinical relapse by a median time of 1.1 years. Overall, MRD conversion in our study was associated with an inferior clinical outcome. Our study shows that MRD conversion do occur in a significant proportion of patients on long-term follow-up, and it can predict future clinical relapse by about 1.1 years. Significance of MRD conversion depends on the timing from diagnosis, and it particularly has an adverse clinical outcome within 5 years from diagnosis. Thank you.